So I know I'm all that's between you and dinner, so I'll do my best here to keep things moving along. I'm sure you're also full of information, and hopefully you won't feel like you're going to explode when I'm done. So there's a lot more in your syllabus than what I'm actually going to have time to talk about. The first thing, just to mention, but more detail in your syllabus, getting the diagnosis right is the first most important thing in patients with amyloidosis. You can do a Congo red stain or do electron microscopy and come up with amyloid, but it doesn't mean that it's immunoglobulin light chain amyloid. In elderly, it can be transthyretin, which has nothing to do with our standard chemotherapies. Renal now, there's LEF2, which is another type of acquired amyloid. And so ideally doing things like mass spectrometry or immunohistochemistry on the amyloid is going to be important because about 10% of the time you can actually have the wrong amyloid even if you have a monoclonal protein. But most of what I'm going to talk about in terms of the amyloid piece is treatment, and we'll go through these topics serially. So using prognostic markers to approach patients with AL. Cardiac biomarkers, things like troponin T and troponin I, but also NT-proBNP, have really changed the way we look at patients with AL amyloid. As you know, patients can have various organs involved. You can have somebody who has nephrotic range proteinuria, feels great. It's an incidental finding because they had a urinalysis that had excess total protein, to somebody who has such bad amyloid infiltration of their heart that they're New York, class 3 or 4, can't breathe, can't walk, and so forth. And those are both patients with amyloid. And there's a huge spectrum in between. And so by not just counting organs, but actually looking at the severity or the degree of cardiac involvement by very simple blood tests, we can really sort of be talking about apples and apples rather than apples and oranges in terms of patients. So when we say it's a patient with cardiac involvement, it's somebody who used to run marathons and now their time isn't as good versus somebody who's in a wheelchair wearing oxygen. And so through the years, we've used slightly different cutoffs. Troponin I and troponin T have different cutoffs. NT-proBNP is 332 was the first iteration. Our colleagues in the UK and also in Italy have looked at this sort of staging and added in using 8,500 nanograms per liter of NT-proBNP as an additional prognostic factor, and also looking at low blood pressure as being something that's going to predict really very, very bad players, patients who are going to die almost immediately versus patients who can do somewhat better. And the last sort of iteration of looking at cardiac biomarkers is actually adding in light chains. So the immunoglobulin-free light chain, the blood test, we talk in terms of the difference, the DFLC, the difference between kappa and lambda or lambda and kappa. So not the ratio, but actually subtracting the two. And if that's over 180 milligram per liter, or if the troponin is greater than 0.03 if you round it up, or NT-proBNP 1800, you actually get a very good sense of if a patient has none of those being high, they can do extraordinarily well versus a group that has all of them high are going to be here, and then you have the other two curves that are the folks that are in between. And the extra lines are the 95 confidence intervals. So you really can differentiate this very heterogeneous population of patients into very specific groups, dealing both with the level of tumor burden or the clonal burden, but also how severely their heart is. And these have become, using these biomarkers has become increasingly important in clinical trials because if you were to test a drug and you happen to choose a population of patients that were in this group, you might inappropriately assume that, oh my gosh, this drug is so toxic, everybody is just dying very quickly, versus if you had a drug and you were treating this type of group of patients, you might think, wow, this is wonderful. The overall survival rate is so much better. And so really all the trials that are being done are stratifying for cardiac biomarkers. So when you have a patient with newly diagnosed amyloid, the first thing that we tend to think about are they transplant eligible or not. And that's not because transplant is necessarily better than the other, but it just starts you thinking about, what's this patient's overall performance status? And so what are the data about transplant? Well, there's only one randomized trial. This was done by the IFM group. 100 patients, and patients were randomized, a multicenter group trial, melphalan plus dexamethasone, based on work from the Italians, versus high-dose melphalan stem cell transplant. And the blue line, the better-looking line, is actually the oral melphalan and dexamethasone group, and the red line is the transplant. What you can see is that there's a very, very steep treatment mortality curve. And what they found is that centers that were not experienced doing transplant, they were the groups that seemed to have the highest treatment-related mortality. And that if one actually benchmarks to expected treatment-related mortality at centers that typically do transplant, we get somewhat different answers. So again, in table form, this is, the blue curve. Their 2-year overall survival just using male deaths is about 65%, but transplant, the 2-year overall survival is about 49%. And if we look at just other series of transplant studies, the 2-year survival rate tends to be around 70% or so, and so this is really an outlier. And so, again, I think it's important. It's a randomized trial. I think it tells us that transplant A should probably be done with people who are used to dealing with patients with amyloid. But also, it also tells us that there are other good options for patients other than transplant. So those sicker patients that one might not think would be good transplant candidates certainly have other options, including melphalan dex and others that we're going to talk about right now. So what are non-transplant options? Well, the hottest kid on the block for amyloid is proteasome inhibition. Bortezomib, we've heard about the fact that plasma cells, just by their nature, have sort of this stress of handling a lot of protein in them, and they're just really primed for hitting them with a proteasome inhibitor. And so bortezomib is the drug that has been studied the most, but unfortunately, and you'll see this in your syllabus, I've listed all the trials, and there's very little trial data. Most of it in amyloid is actually just case series, case reports, etc. The largest trial is a phase 1/2 trial that was in heavily selected amyloid relapsed patients, and that's the best data, but virtually all the other is partially reported, and so on. So what I've done here is I've just given you two, these were published back-to-back in leukemia. It's CTD, cyclophosphamide thalidomide dex, versus cyclophosphamide Velcade or bortezomib dex. And then this is from the UK and this is from Italy, Meldex versus bortezomib Meldex. Again, not randomized trials, but matched. And they were matching it based on the cardiac biomarkers, the free light chain, age, etc. And so probably very equivalent patients. The one thing that they really couldn't match for was the timing. So the patients that got Velcade were the more modern patients. So there's always going to be a potential bias if there are more treatment options in patients that were diagnosed in slightly more modern times. But if one looks at the overall hematologic response, so partial response or better, or the CR rates, so you can see that, again, if you look at CTD versus CVD, the overall heme responses are quite comparable. And same thing, Meldex, bortezomib Meldex, perhaps a little better with the bortezomib Meldex. But what stands out is the CR rate. Adding bortezomib, you do seem to get deeper complete response rates, 40% versus 25, 40% versus 19. When you look at things like 1-year survival, however, again, there's not long follow-up, but they are actually identical across the board. And so those patients that may be dying quickly, this is not clearly salvaging them as much as people would hope, or as they would hope. Progression-free survival does seem to be a little bit better with the bortezomib regimens. So, again, sort of twice as good here, and again, not quite twice as good, but certainly significantly better. So this is kind of some of the best information that we actually have. How does bortezomib perform? This is just sort of hot off the press. It's pre-pub. And this is, again, the Italians and the UK group putting their patients together using cyclophosphamide, bortezomib, dex, 200 patients. Again, not clinical trial. And what you see, again, using cardiac biomarker stages, so both good troponin and good NT-proBNP, these patients do extraordinarily well. Here you're being followed out almost for 5 years, and you can see that nobody has died. If you look at the bad actors, again, these bad actors are still not doing well. And this is the group that everybody would hope that we could sort of bring the curve up a little bit. And it's not clear that bortezomib is doing that for us yet. And then sort of the intermediate patients are doing well. The last bit of bortezomib data is actually this randomized clinical trial that was reported at ASH. It's in part. It's halfway done. There was actually a U.S. companion trial to this, and it closed due to lack of accrual because everybody in the U.S. knew that bortezomib was going to be much better. But Dr. Kastridis reported so far with just 35 on each arm at this point, and so far there is no overall survival difference between simple melphalan and dexamethasone versus bortezomib, melphalan, and dexamethasone. A word about lenalidomide. This is from France, and you can see this is lenalidomide, melphalan, and dexamethasone, very similar to NPR, but we like using dexamethasone in patients with amyloid because you get a faster hematologic response. 2-year overall survival, about 80%, and PFS is about 50% at 2 years. The problem, or an interesting point of this study, however, is in order to enroll, you had to have a performance status of 0 to 1. There are a lot of patients with amyloid that don't have such good performance status. And what you can sort of, and that's kind of in the fine print, this is not as easily tolerated in patients that are sicker. And the Germans present data that basically show that. So if you have patients with more advanced heart involvement, they do not do well. The patients that have much better cardiac function, again, these are probably patients that are PS 0 or 1. These are not. They do not do well here, but these can do okay. So in general, I'm not particularly keen on IMiDs as first line in patients with amyloid. I think the proteasome inhibitors, the alkylators, the steroids really give us the strongest data at this point. Nothing really much yet to say about carfilzomib because that is in clinical trials at present in these patients. The potential for cardiac toxicity is unknown in this very susceptible group. Pomalidomide does also show good response rates. In terms of transplant, so who do you transplant? Do you do induction? Do you use consolidation? Do you use maintenance? What are the answers to these questions? Well, this is some data. It's not published. We're just sort of looking at it. One of the things that we notice that's prognostic is the amount of bone marrow plasmacytosis. That's prognostic. You know that by the free light chain. But somehow that magic 10% point, just like how smoldering myeloma, you go from MGUS to myeloma, that 10% point. In amyloid, the absolute number of bone marrow plasma cells is prognostic, and you can cut it at 10%. Historically, patients going to transplant have not received induction. They just say, we say, here you go, we're going to now take you, give you some high-dose melphalan, and do it and be done. That has served us reasonably well in patients who have a lower bone marrow plasma cell infiltration. So all of these patients are patients who had no induction. And here you can see that the CR and the VGPR in this lower tumor burden group is about 57%, whereas in the higher bone marrow plasma cell group, it's only about a third of patients that get that depth of response. And if you look at actually, overall survival, so what I have here is the 6-year overall survival rate by response. So this is the less than 10%, the greater than 10% bone marrow plasma cell group. If you get a CR, so if you're in this group or this group, the 6-year survival rate is fantastic. It's 88%. However, once you start having less deep responses, survival is worse. And so that has affected our approach, that perhaps our sort of knee-jerk of you take all the amyloids directly to transplant. We've reconsidered and said, you know what, probably should be giving some kind of induction prior to taking them to stem cell, because these patients aren't doing as well. Don't know that it'll make a difference, but let's give it a try. The next question is, who do you transplant? Do you transplant only select patients, or do you transplant just about anybody that shows up on your door? Well, in the old days, or the first folks who ventured into the world of doing high-dose melphalan for patients with amyloid, treatment-related mortality was 40 to 48%. There are reports that high. So selection has to happen to some degree, unless you want to dose reduce the melphalan dose. So you can take somebody to an autologous stem cell transplant, and instead of using melphalan 200 milligram per meter squared, you could use melphalan 100 milligram per meter squared or 140 milligram per meter squared and get them through. However, if one does that, basically, so these are data from Boston. Our data are very similar. But if you use the melphalan 200 versus 100 to 140 milligram per meter squared as your conditioning, CR rates are significantly higher if you are using the higher dose melphalan, so 43 versus 24%. Treatment-related mortality are reasonably comparable. So again, this group that might have otherwise had almost a 50% death rate, by reducing the melphalan, you can get them through a transplant. But again, if you look at event-free survival, it's about half as good if you dose attenuate the melphalan, and survival is also half as good. And I already showed you that we have some other really nice options that one could offer to these patients that aren't transplant candidates, so it's something to consider. Now, the comparison I just made is unfair on several levels. This is not randomized. These patients were obviously sicker to start with, and so they were destined to do less well no matter what. But we know from lots of data in myeloma that the higher dose, Palumbo's data, higher dose melphalan, you get better response rates and better outcomes. So there probably is something to the dose intensification that's important. But there are two schools of thought in sort of the amyloid community in terms of transplant. One school of thought is transplant most patients, but you dose attenuate the melphalan as needed, and then you can consolidate them after the transplant and try to deepen their response. Another school of thought is, you know what, we have these other choices, we have these other treatments, exclude the high-risk patients, just transplant the lower-risk patients. You can get a very durable response. I'll show you some data in a moment, and just take the other patients for other therapies. What do we consider transplant eligible? Again, this is on MSMART. We have these things out there, but it's also in your syllabus. But again, we use physiologic age of 70 as about a cut point, good performance score. We have now recently included a higher blood pressure. Those patients who have blood pressures 90, 80 systolic really do not do well. The troponin of 0.06 is a threshold. And then renal function, New York Heart Class, and then not having too many organs involved. Certainly, there are patients that have 3 or 4 organs, but just a little bit, and we'll transplant those as well. But this is a way of being, quote, a little more selective. Again, a lot of more primary data in your programs, but to summarize, so this is an approach that's done by Boston University and especially Memorial Sloan Kettering, where they say, let's just transplant most of them, but we'll attenuate the melphalan dose. And then sort of this is more, our approach is just exclude the high risk. And you can kind of compare what happens. You have a slightly higher transplant-related mortality in this group because they're higher risk. You do suffer the CR rate a little bit. And your progression-free survival, 3 years, is going to be about 35% versus a 5-year overall survival of 70 to 80%. And if you have a CR, 10-year survival rate of 80%. Similarly, event-free survival is around 3.5 years, and if a CR, the event-free survival is more than 8 years. You sort of question whether you've cured some of these patients because they really do so well. These patients that tend to have lower tumor burden and get transplant. But the other approach, which is very interesting, and as I mentioned, details in your books, folks have tried using adjuvant thalidomide or bortezomib after the transplant. You could argue, do you have to really dislocate somebody from their home to go and give them bortezomib after you do a transplant? That didn't work very well. We will see what happens. You certainly can get the CR rates up higher if you take that approach. Why is VGPR important? Well, amyloid, again, plasma cell disorder, secreting immunoglobulin light chains, making fibrils that deposit in the organs. There's also data to show that the light chains themselves can be directly toxic. So light chains capable of turning into amyloid can be directly toxic to organs. And so dropping the immunoglobulins is really more important probably in amyloid, or dropping the immunoglobulins is more important in amyloid perhaps than in multiple myeloma, because these are direct toxins to the patient. And so again, this is sort of the consensus of response, and you can see CR does better than VGPR, then does PR, then no response. And you can also see sort of how cardiac biomarkers, NT-proBNP, is used to do cardiac response. And so these are patients that have had a 30% reduction in their NT-proBNP versus those that are stable versus those in whom it goes up. And so this is kind of the world of biomarkers. And this is just some interesting data from Dr. Molini's lab, where showing in a worm model, C. elegans, basically how light chains are toxic. And this has been shown in zebrafish as well. But these are really interesting, where they look at the pumping of the hypopharynx in these worms if you feed them light chains. And the light chains can be extracted from a myeloma patient, so you can get it from urine of a myeloma patient or the serum of a myeloma patient, or you can get it from the urine of an amyloid patient who had cardiac involvement, serum of a patient, cardiac involvement, an amyloid patient who didn't have cardiac involvement or just vehicle. And you can see that the numbers of pumps per minute are significantly different in the patients that are given the light chains of somebody who had cardiac involvement, amyloid involving their heart, which is really pretty impressive. And you can do it with recombinants as well. So in terms of just sort of the pathway, if you have bone marrow plasma cells that are less than 10%, our practice is that we don't go with induction. If they have a troponin less than 0.06, they can go just directly to the transplant. If they get a very good partial response, we can observe them. If they don't, and they have higher risk disease, we'll consolidate them. But troponin is one of our real hard stops. So, in terms of the answers, I've sort of told you, induction in some is our view. Transplant select patients, consolidate those that haven't had a deep response. And we're not really advocates for maintenance in these patients. It's, again, in general, unless they have really florid-looking myeloma, very high tumor burden, I think it's hard to justify. These patients are so much more delicate than myeloma patients in general, and sort of the proliferation of their plasma cell disorder is really, I think, quite different. And this is just sort of the formal algorithm. Again, you can find it msmart.org, and there's a recent publication that we just did, sort of giving all the evidence base. For relapsed amyloid, it's kind of a lot like really the newly diagnosed. Again, we suffer from very few randomized trials, a lot of phase 2 data. But what's really interesting about amyloid is this horrible thing where patients just die very quickly. So within the first 6 to 12 months, about 40% of patients die. And this has been true if you look at the 60s to 70s, 70s to 80s, 1980s to 90s, and then the 90s to the 2000s. We have increased the tail of the curve significantly, and it's hopefully a little higher even yet now that patients are living longer and longer. But this part is really devastating, that patients they're diagnosed too late is the problem, and there's too much cardiac damage, and we have difficulty salvaging them. We're looking at doing heart transplant in selected patients, but again, it's a difficult proposition. But what's also very interesting is that the slope of the curve is very different depending on whether it's the beginning of the disease or later on. And so this is the exception where patients with relapse disease or second-line therapy actually do better than patients for first-line therapy. So because already if you've survived long enough for your second-line therapy, you've sort of excluded these people that have sort of died very quickly. And so what's very interesting is if you look at comparing outcomes in AL patients who have second-line or higher therapies, and if you look at a population of 166 patients who didn't have transplant as part of their first line, or if you look at another 146 patients who did have stem cell transplant as their first line, their median survival from second-line therapy is actually 51, 55 months. So it's somebody will say, oh, and it's a relapsed population. Well, in amyloid, that actually in some ways says that they're better actors because you've already lost that population that was the most vulnerable population, and you selected for survivors. A word about ixazomib or MLN9708. Proteasome inhibitor. You'll hear more about this at ASH. There's currently a phase 3 study going on. But the long and the short, just like in myeloma, this drug can give you high CR rates, good progression-free survival rates, and good overall survival rates. And so expect to hear more about this drug. And there is a very large randomized trial ongoing. And then, because of lack of time, there's other really interesting drugs that I'm not going to go into, but NEOD-001, Dr. Gertz talked about some of the results of this antibody that just binds to the amyloid itself and is supposed to be clearing the amyloid directly. What happened? Its time is up. That's the hook. I can still talk. So NEO is an antibody that is actually entering now phase 3 studies. They're doing a study with cyclophosphamide Velcade Dex for newly diagnosed patients with or without this antibody. So we'll see if that really does actually suck the amyloid out from the tissues and allow patients to improve more quickly. You may have seen in the New England Journal of Medicine this SAP depletion medication, sort of a combination of an antibody and a chemical depleter. Again, it was an interesting study. I'm a little surprised it made it to the New England because the responses they used were a little bit weird. But there we go. But anyway, this is interesting to see. But I don't know how well it's going to work in AL, but there are going to be more trials coming. And then, of course, I love the slide about getting myeloma's hand-me-downs. Amyloid is the same. We have all kinds of myeloma hand-me-downs that we look forward to trying out. And with that, I can move on to the conclusions for the amyloid part of the talk. I have a little bit on poems because that was part of my title. But the long and the short with amyloid, getting the diagnosis is really important. Treating somebody who has, transthyretin amyloid with standard chemotherapy is not helping anybody. that you need to really be thinking about characterizing all your patients with the cardiac biomarkers and the free light chains. Clearly, the best treatments are not perfectly clear. VGPR, though, is a good target, even though we don't like it very much, maybe as a myeloma endpoint, but it works pretty well in amyloid. And again, as I mentioned, worse overall survival in unselected, newly diagnosed patients than previously treated patients. And again, clinical trials are really so important in this disease. POEMS syndrome, just a few slides, hopefully, just to basically do a case. So this is a gentleman, 59 years of age, presented with 25 months of progressive neuropathy. He was diagnosed with CIDP, or chronic inflammatory demyelinating polyneuropathy, that did not respond to plasma exchange or IVIG or prednisone. And during this time period, he developed erectile dysfunction, a scattering of cherry angioma, large crops of them on his body, edema, fatigue, shortness of breath. And somehow, after 2 years of suffering, somebody noticed that he had a large plasmacytoma in his pelvis. They biopsied it. They didn't exactly put it all together yet, but they radiated because they saw that there was a plasmacytoma. And this is his plasmacytoma in his pelvis, and you can see it on CT. So it's mixed lytic and sclerotic. And so POEMS syndrome, what is it? It's an acronym for this really fascinating syndrome, even more rare than Waldenstrom's and amyloid, but it's characterized by a neuropathy, a demyelinating, ascending, symmetrical neuropathy, a monoclonal plasma cell disorder, almost always lambda. And then you need to have these two, but you also need to have either sclerotic lesions, Castleman's, or a high VEGF. And then the organomegaly, the volume overload, the endocrine changes, specific skin changes, papilledema, thrombocytosis, restrictive lung disease also is pretty common. And this is a really interesting syndrome where patients can suffer tremendously because they have such disparate symptoms and people don't necessarily put these together. It is not myeloma. Neuropathy is defining in POEMS. It's rare in multiple myeloma. It is the bone disease in POEMS is sclerotic with plus or minus osteolysis, whereas in myeloma, as you know, osteopenia and osteolysis. The clone in POEMS is almost always lambda. Cannot explain exactly why that is. It tends to be low tumor burden, and you know what happens in myeloma. Anemia is rare in this syndrome, where it's common in myeloma. Creatinine being really elevated is very rare in POEMS. VEGF is the cytokine of interest. And the survival, in the bad old days when median survival for patients with myeloma was 3 to 5 years, patients with POEMS had survivals that were, 3 to 5 times better than that. Now that our survival has improved significantly for myeloma patients, who knows what it is for patients with POEMS. So that's good news. But these patients, the other things that patients can have, Castleman's disease and those other things that I shared with you. This is probably one of the more important slides. Because it's a syndrome, it's hard to diagnose, but your pathologist can help you. And so this is an observation that we made, is that patients with POEMS can have characteristic bone marrows. And so one thing that you can see is that if a patient happens to have a lymphoid aggregate in their bone marrow, again, that in and of itself is not a surprising or strange thing. You just may find a lymphoid aggregate in your bone marrow. But if you actually do immunohistochemical staining, so here's the lymphoid aggregate. If you do CD138 staining, you see that this lymphoid aggregate is surrounded by CD138 cells. And if you do lambda and kappa staining, you can see that these are lambda restricted. This you do not see in MGUS. This you do not see in myeloma. Rarely you can see it in Waldenstrom's, but you wouldn't confuse the two bone marrows one for another. So it's actually pretty specific. And so in 32 out of the 33 cases where a lymphoid aggregate was found, they had this kind of rimming. And so asking your pathologist to actually do immunohistochemistry can actually be helpful. And then the other thing, in about half of patients will have megakaryocytic hyperplasia and atypia, and they can often be misdiagnosed as a myeloproliferative disorder. So if you have a patient who has thrombocytosis or erythrocytosis and a neuropathy, do check for a monoclonal protein, and if that is a lambda restricted, you may be very hot on the tail of a diagnosis of Pohm syndrome. And so this gentleman progressed even after 7 months after his radiation. So he came to Mayo. We found his testosterone was low. He had abnormal free light chains, and he had very restrictive lung disease. So how do we manage patients with Pohms? Essentially, if you make the diagnosis, the first question you ask, are there clonal plasma cells on iliac crest biopsy? Obviously, if you put a needle in the plasmacytoma itself, you'll get clonal cells if you don't get too sclerotic an area. But if you just do your typical iliac crest biopsy, if there are cells, then you definitely need systemic therapy. However, if there aren't, and there's more than 2 bone lesions, again, systemic therapy. But if there's 1 or 2 lesions, you may just want to give radiation, treating it like a plasmacytoma, and all of the other features can actually improve. Okay, so what happens if you do radiation? Again, survivals are quite good. However, progression rates, about 4-year failure rates are about 50%. But there are patients that really can do very well with radiation 10, 20, 30 years out, and they're better. Their neuropathy gets better, their lung disease gets better. All these things can just improve just by treating this plasmacytoma. And risk factors for failure are impaired diffusion capacity of carbon monoxide and elevated urine protein. And just briefly, treatments, radiation, standard dose alkylator, melphalan, and dexamethasone. It gives you about an 80% response rate. Corticosteroids can help, but they're not durable. And then stem cell transplant in the majority of patients. Again, there's only 1 reported clinical trial in patients with Pohms, and that was done from China, and it was Meldex. There's lenalidomide trial ongoing, but again, a lot of case series. And this is some of our data. CIBMTR have data that is submitted that's very similar. But the overall survival is excellent, and the progression-free survival is also quite good, with about, at 5 years, only 25% of patients needing additional therapy. And just to give you a sense, these patients may not report dyspnea, but that's because they're in wheelchairs, because their feet don't work, because they have neuropathy. Some may report it. But this is a proper PEA chest x-ray. This is the flow loop curve, and you can even see the DLCO is down. This is after therapy, a couple of years later. Again, they get the muscular strength back, and you can see that they have a much better inspiration, and they feel great. Again, anecdote and small cases for thalidomide, lenalidomide, bortezomib. Definitely lenalidomide, I think, is a winner. I think that it's a very good option for these patients. People are a little anxious about using bortezomib in patients who already have neuropathy, but I've seen really wonderful responses in there, but that's what's in the literature, 5 out of 5 responses. Bevacizumab, which is an anti-VEGF antibody, very mixed information on that, and the details of that are in your syllabus. It is not something I would recommend. And we don't know exactly what the syndrome is. We know that they're plasma cells. We know that there is interaction between plasma cells and the bone marrow microenvironment. We know there can be a monoclonal protein. We know that VEGF and other cytokines are also elevated. IL-12, TNF, rarely IL-6, IL-23. But somehow this plays back and causes damage. This is not a deposition disease. You do not find immunoglobulin in the various organs that might be affected. It's some cytokine-mediated thing. And that's where anti-VEGF was a very exciting treatment that people thought could work, but it's unclear that it really does. And just the final, I think there's a final slide for data. This is looking at VEGF and the sense that VEGF does have some utility in making the diagnosis and in following the disease. And so what you have here, this sort of yellowish haze is the normal range for plasma VEGF. 86 is the number. You can see that patients with POEMS have elevated VEGF. Patients with Castleman's also do. But if you look at things like myeloma or GUS or amyloid, they don't tend to have elevated VEGF. So this distinction can give you some sense of helping you make a diagnosis. If you have other patients with peripheral neuropathy from other causes, again, they tend not to have elevated VEGF. So that helps you make your diagnosis. And finally, the one class of diseases that can have very high VEGF are your connective tissue diseases. And so it's not a very specific, if you have to think, do they have a connective tissue disease? Because these patients can have very elevated levels as well. So, in summary, the bone marrow, the VEGF, a CT, sometimes a PET CT is very useful to really look and help you make a diagnosis. I really like a whole body CT because you can see some of these sclerotic lesions that might be hidden behind gas bubbles in the belly when you just do plain films. And then it tends to be responsive to therapy, and patients can really improve dramatically. The neuropathy tends to take a couple of years to really improve, and so patients and physicians can get very anxious that the drugs are not working or the treatment didn't work. And so typically at 3 months, you'll notice stabilization, for example, after transplant. By 6 months, definitely a difference. A year, dramatic difference. 2 and 3 years, even more difference. But we have a lot of challenges because really understanding the mechanism of this disease and formally studying best treatments is for sure a challenge. And I thank you for your time. This is